What's up? I'm here with a good friend of mine, Lucas.
Hello. Thanks for having me.
You're welcome. Yeah, Lucas is a longtime paramedic and pre-hospital clinician, so he wanted to come on here and just kind of chat about some stuff. Welcome, dude. Tell us a little bit about yourself.
Yeah, you want me to hold it? Yep. Yeah, I don't know about long-term paramedic. Probably a little.
Well, the average career spans 5 years.
That's true. Okay, so paramedic for about a year and a half now, but being in EMS since 2020. It's actually where we first met. You were my instructor at UCLA.
I was?
You were, yeah.
Did you ever tell me that?
I don't think so.
No shit.
Yeah, no, you did.
Damn.
I think you taught me how to use an EpiPen.
Yeah?
Yeah, you were my clinical instructor. Some guy in a Hawaiian shirt just talking about neurotransmitters and stuff while teaching EpiPens.
Have you ever used an EpiPen?
I've never used an EpiPen.
So I taught you nothing that you would ever use.
You taught us ALS Assist too. I remember that.
Oh, okay.
That was a good one. Yeah. So we met way back in 2020, and then we re-met when we started teaching at the same place.
I have no idea.
Yeah.
Holy shit.
Took the EMT class, worked out here in South LA, kind of where you worked. We've worked for, I think, a lot of the same places.
Yeah.
You worked.
There's a couple of standardized career paths.
Pretty
out
much.
Here,
yeah. Yeah. So that's me.
Cool. What's your favorite kind of call to run?
As a medic now, I think as an EMT, it would have been trauma calls. They were always the most exciting. You get to do stuff. Things move fast. We're getting going. Now, I will say probably those kind of complex cardiology calls. Little VTAC with pulses, and maybe they get a little less stable, so you got to do some magic. Got to get some large bore high access IVs and push some drugs, maybe start an amnio drip, that kind of stuff.
Do you have anything like that recently?
I had a couple. Not recently. I've kind of been in a little bit of a white cloud phase as of lately, but we had 3 good cardiology calls probably 6 months ago, all in the same 48-hour shift. So we start with a symptomatic Brady from Classic Nursing Home. They called because the patient was feeling cold.
I wonder why.
Yeah, I wonder why. Maybe because the blood wasn't going round and round. We get there, heart rate of 20. The patient's basically dead, peri arrest. We slap pads on, start pacing instantly. Just no IVs, just start pacing.
Did it work?
It worked great.
Nice.
Got the heart rate up to 60. Got the vasculature up. Skin signs got a little better. She was now kind of ANO 1.5 from 0. So we'll take that. And yeah, just to see, those kind of calls now, that's my preferred kind of call. How about you? What do you like to run?
Man, I didn't even think you were going to ask me that.
Yeah, a little throwing it back there.
I really haven't had anything. Well, I mean, I don't know. I guess my definition of good is different now. And exciting is different than what it used to be.
Yeah, it changes.
Yeah, and so I found the more you learn about the way things work, the less exciting they are, or mysterious. I had a cool call the other day. I had a hypoperfusing 1-month-old baby with a trainee. So I was kind of it's a weird spot to be in. I don't know. Have you precepted yet?
No, I have not.
I'm sure you'll get there. It's weird to stand back and watch someone else do your job and let them make mistakes and fail.
Yeah.
But also catch them. And so this this little 1-month-old baby we pick up from an urgent care, and my trainee, I'm like, hey, dude, go ahead and assess the kid, because it's an urgent care. The kid still has his little onesie on. I'm sure they haven't looked at him.
Yeah.
And so, they took he took the little onesie off, and I was like, oh, look at that. The kid looks like some Colby Jack cheese. He's fucking mottled and breathing at 60. And so, but there's nothing I can really do. I can't get a line on a 1-month-old baby. I can try, but on a hypoperfusing 1-month-old, it's just not going to happen.
Easy.
So I was like, hey, dude, you can try it. Probably not going to happen. It took them 30 minutes in the ED with ultrasound and vein finders and stuff. So I think my calls that I like a lot are the ones where
It's a little complex.
It's very complex, and you have to make decisions that might not be favorable for the patient, but will be favorable, or they don't feel favorable in the moment. like, well, we're going to elect not to get this line because all we're going to do is fuck up any other chance that the people with the ultrasound.
Yeah.
And so I think that's like when you get to the point in your career, and you're probably already there, when you zoom out and look at the big picture and go, well, what's going to happen afterwards? That's the fun part. Those are the fun calls for me. When you go like, well, we're going to do something that sounds a little like it's going to be deviating from the protocol, but it really works out for the better.
No, 100%. And it's interesting because 17 out of 20 calls, we walk in, you know what's going on. You know what's going to happen. The call is going to go like a script, right? Yeah. We're going to do the same stuff. Maybe start an IV, give a little Zofran, transport, and watch the patient. And then the cool ones are the ones where you walk in and you're like, what is this?
And then half the time it's a PE.
Yeah It'll sneak up on you too. But yeah, those are definitely more interesting. When it comes to those 1 month olds, you obviously don't want to go in IO, hit the growth plate, and then they have a little shorter leg for the rest of their life.
We don't dude, I work IFT, we don't even have IOs.
Okay.
And I've brought that up multiple times, and the problem is it's one, money, and then two, you need a QA/QI program, and that costs money. Yeah, so money.
Gotcha. So so you guys gotta get those IVs.
Yeah, IVs or EJs.
Yeah, we just got the permission to go femoral on our IOs, so that's gonna be
femoral IO. Where does that go? Like lateral thigh?
Yeah, kind of like no, actually medial. Medial. And you kind of angle it towards the bone on the inside. You just kind of angle it towards the femur.
That's gnarly.
It's only for pediatrics, small pediatrics.
I was gonna say, you get some big fat dude.
Infants, basically. No, we'll still go.
It is femoral.
Tibial. I guess if they have bilateral knee amputations, I don't know. Maybe they have diabetes.
Yeah, you guys can't do.
We can do humeral head too.
Yeah.
So
you can do all of them.
Yeah,
well, not sternal. I mean, who really does that?
Yeah.
The military.
I think so.
Yeah. Nice, dude.
You ever see any of those?
Sternal IOs?
Yeah.
No, never. That sounds fucking gnarly.
Sounds with the spikes on them, dude.
Yeah.
Imagine getting that shoved in you after you got shot, and you're like, "What the fuck?" It's probably worse than the gunshot.
Dude, I had a kid yesterday that I picked up to transfer him to a children's hospital who had a seizure, and his mom did compressions on him. He started throwing up blood, and then they took an X-ray on him. I mean, the poor lady who thought it was something. So 911 told her to do it.
Yeah.
But this poor lady was doing compressions on her son. He starts throwing up blood, and then they do an X-ray, and he aspirated a shit ton of blood in his lungs. So he's got ground glass infiltrates on the X-ray.
Oh boy.
Probably gonna get a little bit sick. I don't know. Maybe not.
Little early.
Pneuma.
Little young age sepsis, little pneumonia.
Pneuma.
Yeah. Did she break off the xiphoid process or anything, or would she just?
I don't know. I don't think so.
Was she actually doing compressions, or were they kind of the Hollywood tap tap tap?
I think she was actually doing compressions.
Was hit? Okay.
Yeah, because a couple hours later we're like, "How you doing?" He's like, "My chest hurts."
Oh yeah.
Yeah, that boy got compressed.
Dude, I mean that's how. Yeah.
Yeah.
And most of the time we walk in. If there's CPR in progress, it'll be somebody that thinks they're doing CPR.
Yeah, I had the sheriffs one time, God bless him, do CPR on a guy with a blood sugar of 40.
Nice.
Yep.
I mean, yeah, it perfuses the rest of the sugar quicker, so we get more sugar to the brain.
So we can burn more sugar faster.
Absolutely.
Yeah.
I had an interesting call. It was actually not too far from here. It was one of our frequent flyer homeless guys. He went to the ER a lot, probably once every other day. And he was never doing drugs. He was always drunk.
I think I know who you're talking about.
Maybe. Cool guy. He was always cracking jokes. And we pull up. It's like 2 p.m. It's kind of like midday. I think so.
Yeah.
It's kind of actually no, it was earlier. It was 10 a.m. So it was 10 a.m. Get the call, and I was like, oh, this might be the so and so. To my partner who's brand new. It's his first day with me. My partner's on baby leave or something. I get this brand new guy. I'm like, yeah, it's going to be easy. This guy's just drunk. We'll take him to the ER. Get there. Dude's prone on the floor. County sheriffs have Narcan. They're trying to Narcan his nose while he's prone. So they're kind of shoving it in. And, we already gave 8 milligrams to these 2 of them. They're asking for more Narcan. And I was like, hey, let's just roll this guy. Let's take a look at him. And sure enough, he looked bad. But it was the guy. It was the, let's just call him Bob, for the sake of this.
Yeah.
Bob was laying there. He had a pulse. He was kind of breathing. Didn't look like he OD'd. We loaded him up. He was hypothermic, super bradycardic. I was not a medic at the time. We didn't really do any interventions besides, I think we started a line. Maybe I might run that call a little differently now, but yeah, we took him there. They rewarmed him. He actually was in the IC for...
He was hypothermic?
He was hypothermic.
So alcoholics or people that drink a lot of alcohol are more prone to become hypothermic because as you drink alcohol, it scars your liver and you're not able to store glycogen as much. If you're not able to store glycogen as much, then you're not able to mobilize glycogen and your liver metabolism slows down. When your liver metabolism slows down, you lose a shit ton of heat because that is a huge maker of your heat, is your liver. There's a lot of metabolic processes that go on. Yeah, that's why alcoholics get cold super fast.
And then now you see this guy, he's out, he's homeless, he's out, and it's South LA, but it still gets cold at night, especially in the winter. We're in the South Bay here. We got a nice little breeze going all the time. So yeah, he was just wet, wind, cold. Liver was destroyed because we're not talking one beer, a day.
We're talking like fifths of whiskey every couple of hours type of thing.
Yeah. His baseline is a blood alcohol level above the coma level, not the
really
level. Pretty much. Like he was, yeah. He liked himself his brews.
Yeah.
But yeah.
I heard he died.
He did.
Yeah.
He ended up dying 2 weeks later in the ICU. So that was the end of his.
That was it, huh?
Yeah. Yeah, that'd be one of those calls now. That's.
Oh, that you would run differently.
Maybe run differently. That'd also be interesting because it's not a super common or not a super easy call. You have a homeless guy that's passed out. Could it be drugs? Yes. Could it be alcohol? Yes. Could it be hypothermia related? Could it be bradycardia related? Right? There's more to it than just. Oh, he's passed out. Let's flip him and BLS him to the hospital. So it's definitely a lot more to think about. And then we obviously cannot run lab values in the field yet. We can't do any of the advanced stuff. So we don't know. And that's kind of...
I wonder if that's coming. We already have blood glucose stuff, but I wonder if we're going to do anything else.
Like an ISTAT panel.
Yeah.
I think it's possible.
Blood gases, but that's more of a critical care setting thing.
Probably more of a critical care setting. It's definitely possible. I think some areas will probably trial it. We're barely getting whole blood where I work, so that's our newest addition.
Yeah.
Most places don't have video laryngoscopes yet, so I think we're moving there. It's just moving slowly. Very.
Do you guys have VL? I know there was a trial back in the day.
So it's funny. We have VL in a cabinet at headquarters because and we're all trained on them. I got trained on them twice actually. We all got trained.
And you do your quarterly airway lab, right?
Yeah. Yep. The county basically is not allowing us to use them because our operational manager does not want the video footage because they record. It's all recorded. All the intubation attempts get recorded, get reviewed, QA. But the county wants access to all of the footage. And they were like, no, we're not going to give you that.
Why?
I guess they just don't want to share it. Maybe it's a HIPAA problem.
But it's county EMS.
That's the thing. But they're saying, hey, you're not going to use them if you don't give us the video. Because if
we have to QA/QI this. We're the ones giving them to
you. And the argument is, well, currently you don't get to see anything that we do. If we have video, at least, the operational managers and the supervisors, they get to watch what happens. Currently, we have DL. If it's just me, my word goes. So I don't know. It is a very weird bureaucratic little situation we got going on, but
it's weird. I don't see why it would be a conflict.
I don't see why it'd be a
problem. That shouldn't be a problem if it improves first pass rates,
which
it totally does.
It does,
right? And then
yeah. So we have probably 60 of those things in a drawer with hundreds of blades for them.
You know the old saying, how many paramedics does it take to change a light bulb?
No, tell me about it.
12. It takes 1 to turn the light bulb and 12 to resist the change, or 11 to resist the change.
Yeah.
It's ridiculous.
Yeah. What's the other one? 99 years of tradition, or one year of progress. I think I screwed that up, but something
seriously, that's so silly. Do you guys have Decanto catheters?
We sometimes get them randomly. I think supply order people if they accidentally order them. We get them. I like them. They're good.
Yeah.
You can do a little salad technique with them potentially.
Yeah.
That'd be.
What about
something worth
OG
trying.
tubes?
No.
No.
No OG, no NG tubes.
That's weird because in the hospital that's the gold standard, and in some agencies that's the gold standard too. The argument I've heard against that is that you need X-ray to confirm where the OG tube went. But I mean, in the pre-hospital setting, when the ED is going to be 30 minutes away or whatever, like,
Yeah.
does that then like could you do that with an ultrasound probe? I wonder.
Possibly. Yeah.
It's like so progress is just impeded by money and politics.
100%.
Yeah.
Yeah, and I mean, X-ray would be great, and we get why the ERs use it. They can confirm their ET2 placement, make sure they're right
quick,
at the right
it's
depth.
bedside.
It's quick. It's you roll the machine into the room now, and it's just super easy.
You get the whole picture, so you could see like if there's a pneumo, if there's like you could look at everything in there, cardiac silhouette. Yeah.
Yeah. Maybe one day that'll come to ambulances too. I mean, we have CT scanners in ambulances.
Yeah.
Little mobile stroke units.
Yeah. I wonder. It's pretty expensive, the MSU.
Oh yeah.
Yeah.
That's probably a large investment by UCLA.
Mm-hmm.
They have two of them now.
Do they?
They have two. They have a mobile ECMO unit.
Nice.
And they have two mobile stroke units.
Nice, dude.
So
that's awesome. I didn't know they were doing mobile ECMO.
I mean, mobile ECMO. I
Mobile,
haven't
like show up to an arrest.
So I've never
thing,
ran with
like-
them. I have ran with the stroke unit a couple times. I've never ran with the ECMO unit. I would assume if you have like a refractory VFib arrest, maybe, or it's I don't know what the criteria is, but yeah, they should probably show up and maybe point of care ECMO. Be
It's so crazy.
pretty wild, pretty nuts. Wonder what that ambulance build's gonna look like.
Well, there's a fence.
Gotta-
She's not going far.
Got a code gray over there. Oh. I got a trauma. Yeah, definitely. There's a lot for this profession, I think, to progress into.
Mm-hmm.
Obviously, there's a lot of liability issues with giving us new tools like ultrasound. Are we now going to spend 50 minutes on the scene of a traumatic arrest?
Oh, no.
Looking at the heart.
No. Ultrasound's quick, dude. I take a course on it.
Yeah.
It was like a 4-hour video course, and it's super fast. You can get a cardiac exam done in like 30 seconds, if that. Like super quick.
Pretty nice.
You
What do
can-
you think would be the main benefit of having these little POCUS on our ambulance?
Fast exams.
Okay.
Fast exams. You're able to look at dude, think about if you're running an arrest, and it's a PEA arrest, right?
Yeah.
Like you can use ultrasound to determine is this PEA or is it pseudo PEA, right?
Mm-hmm.
Is this a volume problem? You can look at the aorta, you can look at the inferior vena cava to look at how big it is is
Yeah.
it engorged? Well, then now you start going like, do I have an obstruction? Is this a heart failure type thing? You can look at the valves. You can look at everything. You can find a pneumo really quick on ultrasound, super fast.
Yeah, that'd be pretty cool.
Yep.
Or even for difficult IV access.
Yep.
I feel like it could be super useful.
That'd be great too. Access is great. I mean, dude, if people start getting good at ultrasound, if you incorporate that into paramedic schools and make it like 3 day, well, here's the money part.
Yeah.
If you make that a 3-day long course or a 5-day, like a week-long thing with ultrasound, and then all of a sudden now you can train these medics to do central lines.
Yeah.
Maybe
subclavian.
not here in LA where the hospitals are 5 minutes away all the time, but if you're in Bakersfield and you're out in someplace where the transport's 45 minutes or an hour, get a central line.
We have certain parts of our county where we have significant delays to trauma centers. I mean, I work in Ventura County. We have 2 trauma centers. We have Los Robles and Thousand Oaks, and we have VCMC in Ventura.
Best
we have
peanut butter sandwiches ever, dude.
Yeah?
PB&J's at VCMC.
Oh yeah, from the little fridge room. Yeah. If we get a call all the way out in Piru, there's going to be a 45-minute transport to a trauma hospital potentially. Right?
There's going to be a
Depending on
helicopter.
traffic. There might be a helicopter, but it may not be staffed.
Yeah. Yeah, that's true. I didn't think about that. Or weather.
Or weather. We'll try to spin up our helicopter, but it's not always guaranteed that we'll have that. So, the whole thing about hospital transport times, And to me, the example I always make is if you have a call right across from a hospital, you get there. Maybe it's an urgent care or like a small clinic, and it's somebody brought their grandma in with a bad GI bleed, and the grandma or grandpa refused to go. No, I don't want to go. No, keep me home. They finally get forced, go there. Turns out they had a GI bleed for like a week. They're lethargic, they're pale, they're cool. They have a blood pressure of 60 systolic, like they're sick. I mean, we're gonna treat them on the spot.
Oh,
right?
yeah.
Even if the hospitals are right across, we're not going to load them. We're going to start a line.
Yeah.
Where we are, potentially get one of our RAs on, en route and give some whole blood, because we can do all that really, really quickly.
Yeah.
And we're talking straight across the street from the ER. We have to load them up. That takes, maybe we're on the 3rd floor. We have to get into the elevator, collapse our gurney, hit the button, slowly go down, go outside, load them up. It's a 2 to 3 minute process if you're fast. Then we have to drive over, unload, push through the doors. Registration has to come up, put the patient in Epic. Then the doctor actually has to come to a assessment, put in orders. Orders have to get requested. Stuff has to come down from the pharmacy. It takes a long time, right? We can do that stuff a lot quicker. So us having more ability to treat, immediately would be super beneficial.
I had something kind of interesting like that about 6 months ago with Harrington, actually.
Okay.
So we rolled up to this like cancer center that's attached to it's a hospital in Long Beach Memorial. Mm-hmm. And so this thing is like attached. It's part of the campus. And we go upstairs, and this female patient had a carboplatin reaction. So carboplatin is a chemotherapy medication. I didn't even know this, dude.
Yeah.
Carboplatin is a chemotherapy med, and between the 6th or 7th and 9th administration, it's a known thing that they'll have reactions to it. But so we rolled in, and this lady just pale as a ghost. Like, she's alert and oriented times 4. She just looks really pale.
Uh-huh.
Her blood pressure was 60 over 40. Tacky and everything.
Not great.
Not looking good. And so we're trying to figure out are we going to go anaphylaxis or are we going to go shock? So she already had a line. All right, let's get some fluids going. And I was talking to Harrington about it, and I was like, well, what do you think, dude? She's hypotensive, she's pale, she looks pretty bad.
Yeah.
But I also don't see any hives. There's no erythema, So I'm leaning against anaphylaxis and towards shock, because the difference is the way the epi goes in.
Mm-hmm.
Right?
Yeah, you push dose versus IM.
Yeah, so I was like, let's do push dose. And so we ended up giving her some push dose, after the fluids went in.
Yeah.
And then it turned into a base contact, right? And then, hey, Long Beach, we're coming to you. Our ETA is about 2 minutes. And they're like, okay, and we roll in, and we were sitting there on the wall giving push dose for the next 12 or 13 minutes, dude. Pressors. And, she got better. The reaction, ceased, but it does take a while. Especially, you could be sitting there taking care of a critical patient for a while until the hospital gets you a bed.
Long time.
And I don't think a lot of medics are prepared for that sometimes.
Yeah, and then, there's the whole thing about EMTALA. Was it 250 yards from the hospital campus? They're assuming responsibility.
Yep. Unless they have another plan, right?
Yeah. But yeah, if you're there with your patient and they're decompensating and you're the one watching them, it's a pretty lame excuse after to be like, oh, well, the hospital was in charge of them.
Yeah, well, we were within the hospital.
You were standing
grounds.
right next to them with a drug box full of medications and a cardiac monitor on your gurney. Why didn't you treat them?
You didn't. Yeah, you haven't transferred care yet. That's your patient.
Pretty easy argument for a lawyer to make.
Pretty shit excuse.
Yeah. We can definitely get the ball rolling much quicker. Get that definitive, not definitive, but that emergent treatment.
Yeah. Acute resuscitation is literally what the job is, and I think a lot of people forget or kind of discredit that. So your job is, as a pre-hospital clinician, an extension of the physician. Yeah. So act like it. You know what I mean?
Yeah, lift up grandma off the floor and then resuscitate a nearly dead person every now and then. That's what keeps it fun,
Yeah, I don't take credit for a lot. I would say I saved maybe 1 life, 2 maybe. But I've just prolonged a lot of death, dude. It's coming for everyone. Yeah. I just prolong a lot of death on this job. But
yeah, I mean, that's what kind of if you go into this just to save lives, you're going to be disappointed.
You're going to be super fucking disappointed.
You're not going to get to do that all the time. That is going to be pretty uncommon. And you'll get it. You'll get those calls where you're like, wow, like I just, this patient went from a GCS of, 111. Now they're chatting with me. And then especially with us having whole blood, I've been on a call where you gave it once. It was a stabbing.
Oh, yeah?
Patient initially basically unresponsive. I mean, they're grunting the pain. Systolic of 60, pale as can be. We give our whole blood, and 5 minutes later, patient was A&O4, talking, pressure of 98 systolic, kind of right where we wanted, maybe even a little too high. But yeah, make that immediate difference. If we're delayed by 10 more minutes, that's a traumatic arrest, and they're gonna die.
Game over.
We're not gonna get.
I had a triple stabbing one time, dude, which was gnarly as fuck.
Where was that at?
Gardena.
Gardena.
It was a couple years back, dude. I was still in EMT, and we rolled up. Actually, our dispatch hit us up. We were at Gardena Memorial.
Yeah.
And they hit us up and were like, "Hey, can you run a stabbing right now?" And I was like,
yeah,
I probably could do that." And so we roll up to this stabbing, dude, and one of the supervisors from the place we used to work at was there. Panicking, dude, spinning,
Freaking out.
yelling at us, park here. I'm like, dude, like,
chill
out, dude. You're gonna get everyone worked up. And so this guy, I don't know if he was doing PCP or meth or what, but he stabbed 3 people. He stabbed one dude in the head with the fucking knife.
Gnarly.
I don't remember if the knife was in there or if he had taken it out. But
did he penetrate the skull like he was?
Oh yeah. So he stabbed that dude in the head. I don't know if the knife was out or if he had done that. I don't remember who got stabbed first.
Yeah.
We ended up taking a dude who got stabbed in the shoulder, and we took a dude who got stabbed in the back. So we took 2.
Two stabbing patients, same rig.
I think I was driving, so I didn't get to play in the back, but I just remember the medic being like, "Hey, dude, we need to be there yesterday." And I was like, "Roger, hang on,
fly down the harbor."
Dude, yeah. And so I got us there quick. My U-turn was criticized by the supervisors. I was like, "What do you want me to go all the way up to fucking Rosecrans?" Like, come on, dude, fuck off. They're like, "It just looks bad on TV." I don't fucking care, dude.
Nobody's going to care
no
if
one
an
gives a
ambulance that just picked up a bleeding stabbing patient
whips a
ripping
quick
a blood, whips a quick U-turn.
Yeah.
Literally, people would question if you took your time.
Like,
and
why
slowly...
did you go all the way up to Rosecrans?
Yeah.
So anyways, we get down to Harbor, and I was like so glad to see one of my physician mentors actually now was like standing out there. He was a resident, and I was like, "Oh, thank God, dude! Like, this has been a fucking crazy drive." And so we wheel our 2 patients in. The guy with the that got stabbed in the back went in first, and then they came out and got the shoulder guy. Then the dude that got stabbed in the head came in by one of the Inglewood units, I think, and so I think he went straight to the OR. Wow. I don't even think they like stopped in the trauma bay, which is kind of weird. Normally they do to like tube them or something.
Yeah, at least get them tubed and ready to go.
But yeah, so I don't remember exactly what was going on because it was a lot. But then they bring in the guy who stabbed all these people.
Okay.
And he was in cardiac arrest.
Whoa.
And so I'm starting to go like, what the fuck's going on around here? So he's in cardiac arrest. I suspect, and the story was they were like, yeah, he tried to rob somewhere, like carjack someone, and they beat him with a tire iron. I was like, okay. I suspect he was probably doing the excited delirium catecholamine dump thing.
Yeah.
Is what I was thinking now. Back then I was
Back then you're just like...
Back then I was like, crack his chest. So, they work him for like 20 minutes, dude. Yeah. And he ends up, they call it, he expires. And I'm walking out. And as I'm walking out, he's in like trauma 4. I walk by trauma 3. It's fucking shoulder guy. Peace out, dude. And I walk by trauma 2, and it's stabbed in the back guy. And as I'm walking by, they're like, "We need a doctor in here." And I was like, "Oh, what's going on?" He arrested.
Nice. Okay.
And so I was like, holy shit, dude, it's really rocking and rolling here today. I just like that dude. They literally called about a minute ago. Now this dude's arresting.
Yeah.
And so, they did, I think they decompressed him and then gave him a unit of blood, and he woke up.
Gotcha.
Like, woke up within like a minute.
Yeah.
And it was
the
like,
blood is insane.
whoa,
the
dude.
blood makes a big difference.
It's crazy.
It's almost a wild concept. You're losing blood and you're getting blood and you get better.
Yeah. Crazy.
Crazy. I wonder so it got stabbed in the shoulder. I mean, the lungs go pretty high up. Could have definitely...
No, there was shoulder guy, and then this was back guy.
Oh, back guy. Okay.
Yeah.
Okay.
So totally punctured his pleural. Sorry,
Yeah.
that's a spit idea.
You're all good.
Yeah, crazy. I remember being like, wow, this is fucking gnarly.
That's a crazy.
It was.
That's a good one. I was watching the new TV show The Pit at Station
Oh, that's
with
a good
my
one.
partner.
Yeah.
And you know, we work in kind of a slow city or hospital. They don't get too many patients. And he's kind of like talking about how it's a little unrealistic how many critical patients they're getting in this 1 hour shift or this 1 day shift because it's supposed to play over like 1 day. And obviously it's Hollywood.
Depends where you work.
They upplayed it, but then you have that, and then you're at Harbor UCLA,
Oh, yeah.
and all of a sudden you get 4 traumatic arrests in an hour.
Or,
you know,
or like being a paramedic, dude, like working in Compton, especially when the weather gets hot, people are outside because, like, dude, there's, maybe they don't have insulation or air conditioning.
Yeah.
People are outside on the street, like, drinking and starting beef with each other. And what'll happen is, I mean, you're aware of this, like, there will be one shooting, and then 20 minutes later, another shooting because everyone's like, hey, we got to go get him, right? And so you can run 2 or 3 GSWs in a shift.
Yeah.
And people are like, I guess, they're like, oh, being an EMT was boring. It's like, well, where the fuck did you work?
Exactly. It makes a huge difference. People talk about working in, like, terms of years. Oh, I worked for 16 years in Panhandle of Oklahoma. Well,
cool.
How many calls that you run? Like, how many? Maybe some like hillbilly fights, but probably
hillbilly fights and CHFers. But
yeah. No, where you work and makes a huge difference on the experience you get and how you actually feel about the job. Because if you work IFT for 3 years, never step foot in a 911 ambulance, all you do is take. Say you work for PRN, you go to Kaiser.
Well, then your EMS experience is going to be vastly different.
Horrible. Yeah. You didn't work EMS. You worked emergency medical, or not even emergency.
You worked
medical
like
transport.
Scheduled transport.
Yeah. MT, medical transportation.
Yeah.
Technician.
That's
very different.
horrible.
But that's why it's fun. Starting out with South LA McCormick Ambulance was definitely a change. I mean, I didn't realize when I went to EMT school, I didn't realize the difference between IFT and 911. To me, an ambulance was an ambulance. A fire truck was a fire truck. I don't even know those guys were paramedics.
Yeah.
That was new to me. So when I did my ride-alongs with McCormick, I was like, this is fucking sick. Like, oh my God, we had some good calls. And I remember on my first ride-along, it was out of Hawthorne, Station 10, ultimately where I ended up working. Our very first call was a pediatric seizure at like a daycare. If I run that call now, I'm like, okay, it's a febrile seizure. Like, it's no big deal.
Big chillin', put a wet towel on them, BLS.
Yeah, it's literally. And
you could still send those BLS, right?
We can technically BLS those calls. I would probably sit back there.
Yeah.
I wouldn't give it to my partner, but we could technically BLS that call. It's not a real bad call. Back then, I was like, I was spinning. I was like, whoa, like we didn't talk about this in EMT school. What am I doing? Baby seizing. Like, oh my God, we need an airway. Somebody do C-spine. Definitely exciting
give me a tourniquet.
And the medics were like, we're flying code 3 to Harbor. That was the first hospital I ever transported to.
Oh yeah. That's always been like my lighthouse. Like you can be running a gnarly, scary call, and as soon as you like pull into Harbor,
you feel that relief.
like thank God, dude. Yeah.
You're making that turn, hit that last little bump.
Yeah, the bump coming into the driveway.
Yep.
Like, oh God.
Yeah. You park and you're like, okay, we're good. I loved going to Harbor. We had one traumatic arrest, bicycle ped. It was at the intersection. It was in Lawndale. I forget exactly where, but it was residential. Yeah. We got there. She's in PA.
Okay.
Unknown when she got hit.
Probably an exsanguination arrest.
Possibly, a little internal bleeding.
Yeah.
We fractured pelvis. We load her up. We load and go. It's a traumatic arrest. Bilateral needle decompression, just in case it's a little tension.
Yeah.
Tension pneumophysiology, but doing compressions the whole way in. Medic starts bilateral 16 gauges. Was able to get them.
Nice.
So very, very, very clean.
Good for you, whoever that was.
However, that was part of the problem in this call. I guess when he uncapped his IV and he put it in great. The lines were great. We get to Harbor, and my partner runs out back. I stopped compressions. The medic's taking over compressions because I was going to start unloading the gurney. We have the little like auto loaders at McCormick. The one thing I miss about that place are those.
Yeah.
But I push the thing and I'm trying to pull the gurney out and it's not coming. And I'm like wiggling on it. I'm jamming.
I already feel like this is not going to go.
And it's not going. It's just not coming out. And so my partner comes around back. He's like, "Oh, what are you doing?" Like he's trying. And it's like not going. One of the the squatties walks around back like, what are you guys doing? Get the gurney out. So he's trying.
Dude, this happened to me on a call, actually.
Really?
Yeah, and we had to get another unit.
But now, mind you, we're at Harbor.
In the ambulance
In
bay.
the ambulance bay.
Oh, God.
There's registration behind us trying to get info so they can already get registered. We can't get the gurney out. So we're like, hey, guys, get a bed out. We're going to just move them straight to a bed.
Was she on a flat or a backboard?
We had a backboard.
Okay.
This was,
Yeah.
It wasn't a big problem, but it was just like, oh, boy. A Harbor within 20 seconds, rolling out of bed. We backboard them out on the bed, and then the doctor pronounced in the bay. Like, we never made it past the doors of the ER.
Yeah.
The doc was like, no. What happened is the IV, the little clear plastic piece of the IV catheter got jammed in our autoloader track system. So it had to get taken apart and like removed, and Stryker had to come like fix it. It was that thing was totaled basically.
Wow.
One little
it,
piece of plastic
totally ruined it?
Yeah. Totally,
oh my God.
Totally messed it up.
Damn.
Yeah, so I try not to throw those on the. I mean, we don't have autoloaders, but I try not to throw those on the ground.
Yeah, that's something that I've kind of like, as I've gone through the years as a medic, like I'm a lot more. It's almost like when you first start cooking.
Yeah.
Right? And you're like, shit, I'm just trying not to burn the food, right? I'm just trying not to kill the patient. And then you start getting good and you go like, well, I've kind of made this meal a couple times before. I know what I'm doing. And then you go, oh, like I've done this so many times that now I'm cleaning in between. Right.
Yeah,
so like start a line, clean up, strip a bag, clean up. And then by the time you get to the hospital, like the rig's already clean. You know what I mean? So I think that's part of the style that, you'll develop as you go through. If you're watching this and you're getting into EMS.
Yeah, try not to be a messy medic.
Don't be a messy medic.
Trash all over the place.
And don't be a cookbook medic either.
Yeah.
Yeah.
That's a big thing, especially for new medics, is because these policies get so drilled into you, right?
Yeah. You
are doing your policy drills. You have to memorize the sheets. And you get stuck in this mindset of, hey, this is the policy. Okay. You walk on scene. Which policy am I picking, right? What is this? Is this nausea vomiting? But it's not always that simple.
Just take a step back.
Do the medicine first. Get an overview. You might pull a little piece from each policy, change them a little bit, adapt, and don't be a cookbook medic. It's not a black and white.
Don't do that.
Black and white call. It's a complex call. Sometimes.
Yeah. Can be.
It's funny. Harbor has always been my. And I still, even now, I haven't transported there in years, but it's still the hospital I think of as like my trauma center. Like, that's where I've taken all my crazy traumas. I barely get traumas now.
Yeah.
We had I've had one gunshot in my year and a half working in this county now.
Oh, really?
Just one.
Was it good?
It was an interesting one, actually. So I work in the city of Simi Valley, which is the very kind of east city of Ventura County, bordering LA County. And there's a little LA County like town called Bell Canyon, and it's like in the mountains. They have a BLS fire engine, and that's it. They have a BLS fire engine. So they had a shooting go off. They don't have any PD in that town. LA County Sheriff's doesn't cover it. LAPD doesn't cover it. Our town, Simi PD, doesn't cover it. It's Ventura County Sheriff.
Oh, that's weird.
From Moorpark. So they have like a 20 to 25 minute response time.
Yeah.
We're dispatched along with LA County Fire, and we're staging, and we're waiting for PD because we have no PD. There's an unknown shooter. PD finally gets there. 3 cars. If you remember shootings in LA, I mean, how many LA County sheriffs showed up? Like 40 of them, right?
Yeah,
they all came.
You get a bunch of cops.
Get a bunch of them.
Crime scene tape up immediately.
Everywhere.
Yeah.
We had 3 cops. One of the cops was actually my partner's dad at the time. So he's like.
This sounds like rural, dude.
Yeah.
He was also the mayor.
Yeah. So and they radio in like, hey, we didn't find the shooter, but you guys can come on in. We're like, okay. So we drive. Battalion chief at this point showed up. We kind of follow him in. Driving up. It's a super steep driveway. The engine can't make it up, so we have kind of everybody hop into our ambulance.
Nice.
We've got like 6-8 guys in the back.
Yeah.
We're all driving up. 2 people immediately hop out, run into the house. I'm in the passenger seat. I hop out. I'm the first medic in, so I kind of walk in after them. And I'm hoping the guys are going to bring all the equipment in. Because we had so many people.
Come on, guys. All of you just hopped out?
No, just 2 of them.
Oh, okay.
So the equipment was brought in. Everything went good, but I'm kind of walking in. And I call out, this is a large home, nice home, with nothing in it. No furniture, no nothing. Super weird.
That's weird.
Hardwood floors, echoey. I walk up the staircase, get to the front door, walk in, like, hey, where are we all at? And I look up, and I'm like, I see a blood spatter at the top of the stairs. I'm like, that looks like where they might be. So let me go up the stairs. Again, like, I'm not by myself in this living room. Walk up, and I see the sheriff's department and the 2 firefighters kind of with the guy who was laying on a mattress in a large just room with, again, no furniture. It was just a mattress.
Was it like squatter's house?
No, I don't know. I think they did own it. I actually know they did.
That's all they owned.
But that's all they owned. Giant dog next to him. One of the largest dog I've ever seen.
It was huge.
It was
huge. A good boy.
It was like a Rottweiler mix. Like,
get this fucking thing out of here.
So I walk in the room, and somebody's holding pressure on his chest. The cop is trying to calm him down by doing like breathing exercises. That works for anxiety attacks. I don't know if it necessarily worked with the through and through to his chest, but he's trying to calm him down. Everybody's trying. It's this dog's just sitting there, and I walk in. I'm like, I point at the dog. I don't even say anything. Like, we tried. He's just sitting here. He's fine. I'm like, well, he's fine now until I shove a needle in this guy's chest to decompress him. I don't know what he'll do then, but whatever. We couldn't remove the dog. So I walk in. I take a look at it. It's your classic like bubbly chest wound. Like
left side.
Left side, just lateral to the nipple line.
Oh, that's a good place. That's a better place.
Yeah. Probably like 4th, 5th intercostal space. We have the commercial chest seals, which are nice. The prevented ones. So we slap one on. Exit wound on the back. That's kind of just oozing out blood.
Yep.
Slap another chest seal on the back. We got a blood pressure initially of 128 over like 80. Mind you, this was after a long staging time. So we're like, okay, like it's definitely like they didn't hit the heart. We know that. It's not a tension pneumo right now. We know that. We had good lung sounds too. Maybe barely diminished on the left, possibly a pneumo, but not a tension pneumo at this point. So he's still alert. His skin signs weren't terrible. The problem was he's a 6'6" guy.
Oh, and you're at the top of the stairs.
Top of the stairs, and a little husky. The staircase was super narrow, so it was tough to 4-point like a board or anything.
Hey man, you think you could walk down the stairs for me?
Ultimately, we decided on a stair chair.
Okay.
So it's a little unusual for a gunshot wound to stair chair, but all right. So
do what you gotta
my
do.
supervisor got on to him. I was like, hey, can you grab a stair chair? And he's like, okay. He runs down, grabs a stair chair. We load him up. I'm at the top of it. This guy's back wound through the chest seal is now leaking out blood all over my boots. I'm like,
oh, you sat him up and it started to go.
This guy's actually bleeding. Let's get this guy supine again.
Yeah.
So we're moving him. He's dripping blood. We get him in the back, and he's still fine. Like, he's talking to us. We get lung sounds again. They're still the same. We have good lung sounds. Pressure a little more soft, 106 over like 70. We had the RA get their blood. We didn't prepare it yet. We prepared some TXA, some saline.
Great.
Got IV access. Called the hospital.
And you have to go to Robles from there.
So
right?
From there, we're going to go to Northridge just because it's so far on the corner.
Yeah, that makes sense.
But yeah, we load him up, we transport him. I had a new partner at the time driving. He's hitting turns fast.
Oh, fuck.
One of the firemen flew over the gurney into our cabinets, shattered the doors.
Oh,
we told him, hey, slow down a little bit.
Hey, dude.
This guy's fine.
It's not that serious.
He starts decompensating a little bit. We still have good lung sounds.
Had him on O2.
Put him on O2, transport, and just watch him. Ultimately, yeah, he was all right. So that wasn't a crazy gunshot. The wild thing is, we get dispatched out to a overdose a month later. The same house, same guy.
Same guy.
Overdosed. Cardiac arrest.
Oh,
medical etiology.
Done. Well, so I wonder, did he overdose on prescription meds that he was given after his GSW?
I don't think so. I think it was a drug home.
Oh, okay.
There was some paraphernalia on scene.
Yeah.
But yeah, super weird. I saw that address and I was like, I'm kind of like mapping it. I'm like, no way, dude. We've been here before.
Yeah.
Not again. Dog wasn't there, so that was.
The dog was not there.
Was not there.
Oh.
But I didn't run the arrest. Somebody else ran it.
Yeah.
But I just saw the address come out, and I was on a different unit that day. I was
because
like,
you can see whose calls are going out across that county.
Yeah, we have a nice little computer
System,
in our front screen where we can actually see everything. It's one of the big differences to McCormick, where we both used to work.
Yeah.
Yeah, I mean, you got an address, and that's kind of it. They're like, hey, go here.
You remember map books?
Yeah.
Yeah, the Thomas Brothers map guides. I mean, now they have like CADs with auto GPS, but like back when we both started in EMS, we would get a map page and a grid along with our address, and we would have to like flip to the map page that was on, go to the grid square, find the streets, the cross streets, and then flip back and figure out the fastest route. And you had maybe 30 seconds, right?
Yeah.
Yeah.
And then if you didn't pick the perfect route, you'd get like contacted by dispatch.
Oh yeah, and then they would judge every single turn you make.
Yeah, it's wild. I had to buy my own Thomas guide.
Yeah, so
they made me purchase it during orientation. They're like, hey, by the way, it's a $40 book. You'll have to buy it.
Yeah.
Put your name on the front because people steal them. I'm like, what?
Yeah, I remember that.
I was like, I have Google Maps. Like, can I not use that?
No, you can't.
Nope.
Come on, man.
Not officially.
Well, yeah, not officially. Yeah.
But yeah, big change to now having a literal computer screen. We have a nice large, I don't know how large it is, but it's big.
We got something like this in ours.
Yeah.
Yeah.
Yeah, it's like one of those large iPads probably.
Yeah.
It's responsive. They work even in 100-degree heat when it's on the front dashboard. It still functions, so. It's a luxury, just being able to see every call, seeing where units go, reading the notes.
Dude, I was working out there one time and I saw a tiger attack go out across the county. I was like, who's got a tiger? We looked at the address. It was like some residential house. It was like, maybe it's just a big house cat. Maybe it's a bobcat, but like a tiger attack?
Was it a real tiger?
I don't remember. I don't think so, but just weird.
Yeah.
It was kind of cool.
Yeah, we mostly have stationed units, but when we have a few day cars that we just post at intersections. I don't pick those up a lot, but sometimes we get mandated.
Yeah.
The nice thing is, call goes out, you can read the notes, and sometimes they're silly. Like I remember one, RP states wife passed out in dumpster again.
Again.
It's again at the end.
I had one dude. It was RP states his head is shrinking.
Nice.
So we get there, dude, and he's like, this dude's convinced his head is shrinking.
Yeah.
Oh yeah. And so
a small head.
No, dude, just normal. He's like, dude, my head's shrinking. It's gonna implode. No. I was like, are you taking any psych meds? He's like, I haven't taken them in a couple of days.
That's why your head's shrinking.
Gotcha.
So these ones, they're actually anti-shrink.
Yeah.
Go ahead and take 2 of them right now.
These are head expanding medications.
Yeah. My favorite one that we get sent out to so we get a text. That's how we typically get dispatched. Our station tones go off. We get a text with just the very vague chief complaint. This came out as a hazmat. So we're like, interesting. We're getting attached to a hazmat? Like, this is sick. So I walk out to the rig. I put us en route, and I read the actual notes. RP states husband covered himself in bug spray to fight off imaginary crabs, was the direct quote of this call. Now bleeding from nose. The next line.
He lost the fight against the imaginary crabs.
So we're like, what is this? We're dispatched. We get there, and sure enough, it's a 60-year-old male, naked, covered in fluids, bug spray, bleeding from his nose.
I was like, damn, I knew he was going to be naked. How'd I know?
Yeah. I mean, potential organophosphate poisoning, maybe, but probably not. Turns out, he covered himself in bug spray, slipped, and fell. And that's why he's bleeding from his nose or mouth, whatever it was.
Oh my god.
He was
that problem took care of itself.
He was totally fine, but
the imaginary crabs tripped him.
I made sure to call the hospital for that one and give them a direct quote of what we got dispatched to.
Yeah, hi, I'm calling a report of chief complaint we're being overrun by imaginary crabs. That's awesome.
It's those calls that keep the job fun.
Yeah.
That's what you're looking for. When you're just like, it's the second day of a 48-hour shift, you're busy, you haven't slept yet, you walk out and you read that, and you're like, oh my god.
Yep.
Your partner walks up,
Dude, check this out.
Check this out.
I remember the first PCP guy I ever encountered was fist fighting a parked car.
Yes.
And
same.
And he lost.
They Donkey Kong smashed the front of the hood.
Yeah, and I think what happens is like they see their reflection.
Yeah, they just get angry.
And they just get angry.
Can't take it.
Yeah.
This was actually, I think that's why I was getting to that earlier. Like on my very first ride along, we had a little PCP patient. I'm wearing my white shirt. I don't know what's going on.
Yep.
We pull up to this psych call. I'm in the back of the ambulance. I can't really see much. I hop out, and this guy's just beating the shit out of the car, just smashing it. And I'm like, whoa.
What's going on?
This is a big guy, too.
Yeah.
That was a fun call, yeah.
It's like moths to a light.
Yes.
Literally. PCP guys to cars. Moths to a light. Yeah.
No, like I said, it's 17 out of 20 calls are boring. It's grandma falls, she's on blood thinners, we take her, gets a CT, okay.
Chest pain.
And then occasionally you get the fun ones.
Yeah.
And that's where this job is actually worth it.
It's a blast. It's a blast. I saw I remember when I was working up in Ventura County, I saw body cam footage from, I think, Oxnard PD of, it wasn't me, dude. I was on this call. It was someone from that agency that, you know, you work for.
Yeah.
Or that I used to work for, pouring milk on a lady who got pepper sprayed in a 7-Eleven parking lot. And she's like, and he's like, just pouring the milk.
Just pouring milk.
So like, you know,
I need
hey
some
honey,
milk.
like, how was your day at work? Like, oh, I was good. Poured milk on a lady. Like, who else gets to do that? You know what I mean? Who else does that shit?
Walk in the 7-Eleven. Hey, I'm confiscating your milk for medical reasons.
Yeah. Hey, is it cool if we take this milk? I guess.
The clerk would just stand there like, what?
Do what you need to do.
Yeah. That's funny.
Yeah.
You worked for...
Yeah.
Okay, yeah.
Yep.
That's what it was.
That was a cool place. Cool place to work, but long drive.
Well, yeah, this was fun. Thanks for having me on the
Yeah, man.
podcast.
Absolutely. We'll do more of these too.
Yeah.
This is a cool first one.
We had no script.
Two medics chatting over some coffee.
Yeah.
That's really it.
Just a little morning coffee talk here.
Cool. All right.
Alrighty. Use your microphone. I think I've been holding that.
Lucas and I are going to go crush some beers and do belligerent things. So, cool.
Yeah, we'll have some fun.
See you later.
Peace.
All right.